Cool. Well, good evening, everybody. My name's Harriet. I'm the medical director of Livi, and I'm joined this evening by Neil, Dr. Neil Smith, who's going to be talking to us about cancer diagnosis in primary care, particularly in remote general practice. And then we've also got Dr. Hemelshaw, who is associate medical director, who's also going to be adding some of his pearls of wisdom from his work within the remote team. If we could move the slide on. Quick overview of Livi. We're not going to dwell on this because tonight's not about Livi. It's about picking Neil and Hemel's brains as much as we can about cancer care. But essentially, Livi is a digital online provider, and our goal is to provide great healthcare for all and to deliver the future of healthcare. Next slide. So we have many NHS partnerships. So I think I've got about 21 at the moment. And it's all about increasing access and reducing inequalities in access to healthcare. So we work with well over 350 practices across the UK. We have access for over 6 million NHS patients. And I think we've done over 300,000 meetings in the UK and over 3 million meetings completed across Europe. So we've been pretty busy. And we have over 350 happy employed clinicians. So we're getting to be quite a big size and we're very proud of what we've achieved. So that's whistle-stop tour of Livi. Let me give you a quick introduction to Neil, and then Neil can tell you the rest about himself. So Neil, as I discovered today, was one of my trainers when I was a medical student. Neil is a GP with an interest in cancer care, works up in Blackburn. He is keen runner and does the on-site care for Blackburn Rovers, I think it is. But Neil, tell us more about yourself.
Thanks, Harriet. It's much thanks to Livi and you and Hemel and Bobby for this. It's a fantastic opportunity. Yeah, my name's Neil Smith. I'm a GP. I've been a GP in Blackburn, my hometown, for nearly 30 years. I'm not sure why I've ended up going back there after the one place I didn't want to go back. It's very deprived. First 10 years of my career, I spent a lot of time filling this book in, which is my death certificate book. And I kept writing malignant neoplasm or metastatic disease due to, and I just couldn't get my head around it. What was I doing wrong? And about 15, 18 years ago, I had about an epiphany moment, and I just thought, there's something that I can do here to try to make a difference. First of all, for my patients, and I've had the great privilege of working for lots of cancer charities, initially Macmillan, and now I am supported by Cancer Research UK, and I do some national work and some media work for them. And the biggest thing is I do think that we can all make a difference with cancer care, and the most important thing is early diagnosis. So one of the things I'm hoping to do today is just to share that with everybody who's in the audience, to try to make a difference. What I'd like to do is, by tomorrow, if you're seeing people, you just feel a little bit more confidence and competence in that earlier diagnosis of cancer. As well as being a GP, I do quite a few other jobs. I've done lots of education. I actually met Harriet when I was the Associate Dean at Manchester Medical School, and she actually came to Blackburn Rovers as a student, and this is me and my team, and we're doing something for prostate cancer outside the ground, actually multitasking. And the other thing that I'm really proud of, this sounds absolutely wonderful, I am an NHS triathlon champion. Now, doesn't that sound absolutely great? And it's on my CV, but they only run it last time 3 years ago, and they had a special category for all the men. And I was delighted. There was hundreds of people took part, and there was only 2 old men in the whole race. And this guy was much, much better than me. He got out of the pool and started running to his bike, and he pulled his hamstring. So I was the only finisher, and I've got that on my CV forever. And many thanks for everybody joining us. I know it's 7 o'clock on a Tuesday night, and you've probably all had a busy day, and so I hope today's worthwhile for you. So what I've tried to think about, I'm very much in the mindset of the way GPs think. You know, I certainly can walk the walk. I hope I can talk the talk, and I really want to help you in your increasing your awareness of potential signs and symptoms, to help you with your assessment skills. There is definitely something about digital health. I'll be transparent with you. I'm a GP. I'm sort of a traditional GP. Of course, I do some digital issues with my patients, but I'm very grateful that Hemel's going to step in intermittently if there's additional things and things I'm missing, particularly for the Livi doctors or people who exclusively work remotely. But to be honest, there isn't that much difference, and that's one thing that we're researching for this has actually crystallized for me. I'm really keen to just help you with the simple investigations, referral, and just be safe. And then also, as I'm presenting, all this is going to be videoed. All my slides are for you for free, and I've got quite a few resources that you can have and keep, all nationally available, or things I've created myself. So the other facet to my job, I'm at a stage in my career, I only want to work with nice people, seriously. I only want to surround myself with people that actually I do think making a difference. And I really do. I'm not selling Livi at all. They are the good guys as far as I'm concerned about digital healthcare. And I saw him at the time when this photograph was taken a few months ago, my daughter, Amelia, was working for Livi, and she said, I have to get a photograph with her crew. And I got these freebies. And we started talking about doing this event because I was presenting at a national conference on this, and I'm really delighted to do that. And actually, the interesting thing, Amelia's left, but my youngest son Ruben also, if you're a Livi GP and you spend time like on a Saturday doing your surgeries, my son is one of the people who administers it. He does set watching football while he's doing it, I must say, but don't tell anybody of the management structure about that. And he gets well paid as an 18-year-old. He's just gone to uni and he's still kept his job. As I said, Livi, I'm not here to sell Livi. It sells itself. And I have something that's outstanding. My practice isn't outstanding. And it really made me think about what Livi are doing differently. And I think it's about the right people doing the right things for the right reasons. And that's why I'm delighted to be associated with them. And if you're very good about things, and this is parallels to cancer and cancer care, you've got to actually be human with it. And cancer is not just about a science. People want binary answers, yes, no. It isn't about that. It's about the softer things. And as GPs, as well as scientists, we are artists, and that's what happens in Livi. Success is mixture of the two. And as GPs, we've got to think about that. And what I want to just extend is that artistic bit. In the last year or so, I've got a little bit obsessed with Portrait Artist of the Year. If anybody's watched this, it might not sound really boring, but if you get into it, it's just amazing. So what happens is in Portrait Artist of the Year is that a sitter comes in, we've got examples of them, an artist sit around and they spend 4 hours to create an image of that person. And then, the good image wins and they get through to the final and ultimately get a commission. Now, this was really made me think about how we diagnose cancer as GPs. And what happens is we have a patient and the patient is our blank canvas. And we use whatever resources as artists we have to actually create a clear picture of that patient, which gives us an assessment, first of all, definitely the risk of cancer, and then ultimately the diagnosis of cancer. And what tools do we use as artists? Well, it's simple. It's history, examination, investigation. But as you will find, as I'm talking, it's almost always history. And that's why it doesn't make that much difference, digital or physical face-to-face with patients. So, I'm going to split this into two halves. That's my preamble over. And what we're going to do, first of all, for audience participation, we've got a quick quiz. Only 10 questions, and each one's a pretty simple answer. I'm not worried. It's just, you'll have to be too competitive. But similar to me, when I got my bag of goodies from Livi, I think the winner's going to get a bag of goodies. Bobby's running this in the background. I think we're going to go low tech. I think we decided it was too hard to try to do it. So we trust everybody. We want people to just write down their own answers and we'll score it at the end. And whoever gets the most is the winner. And if it's a tie break, we'll have a bit of a tie break question. Is everybody, I hope everybody's willing to participate. I must say that the prizes are very good. I've still got my special Livi cup here, which I absolutely love because it keeps my water chilled at work. So pretty straightforward questions, and I'll try to use this to then expand into a little bit more information. So first question, really, really easy. What percentage of the population die from cancer? So please, 10 questions, 10 answers. If you can write them down, and I'll give the answers straight away and we'll go along with it. So everybody wants to engage, please do so. Thank you. So, and I'll move you on forwards. You've got a chance to answer 5, 4, 3, 2, 1, and the answer is 25%. So 25% of the whole population. So if you have a look at that in figures, right, that's 167,000 a year. So you think about it, since the beginning of the COVID pandemic, in the UK, more than twice as many people have died of cancer since COVID. And that's not a one-off, that is year on year on year, and will continue. And actually the numbers are growing. Another way of looking at that statistic, very, very sad to say that 1 in 2 of us will get cancer. Some people in the audience may already have had cancer, certainly no family members. Cancer affects everybody. And of that, 1 in 2 of those who get cancer, as in 1 in 4, will die of cancer. But if you have a look at actually premature deaths, so people not dying of old age or advanced dementia, cancer is even bigger than that. 42% of people who die under the age of 75 die of cancer, and now it's bigger business than the next three combined, be it cardiovascular, respiratory, and liver conditions. So it's absolutely huge. We've done masses in the last couple of decades about cardiovascular outcomes, but sadly, cancer as a death is increasing, mainly because people aren't dying of other things, so they're dying of cancer. Right, so fantastic piece of research. As I said, I'm very proud to be part of Cancer Research UK, and a lot of things I'm showing you are from here, and I'll give you the resources as we go along. So they did a piece of work to ask people, this was the general public, to say, the word cancer, what words do you associate with it? And these are the words, incredibly negative: death, fear, illness, disease. You do the same in GPs, fill in the same words and add one other. And the other is litigation, because cancer is the one thing, as people we fear the most, and as GPs we fear missing the most. And I'm not going to solve all that for you, but I just hope that at the end of the next hour you feel a little less of that fear and that negativity, and we can turn that around so it's a positive outcome for you and you feel more confident. Question number 2, which cancer's got the highest incidence? So this is the number of cases diagnosed each year. Is it lung, bowel, breast, or prostate? Time to think. Answer. And the answer is breast. Okay. So figures from Cancer Research UK. Those are the big 4, over 50% of cancers. So if you worry about cancer and diagnosing cancer, if you think of breast, prostate, lung, and bowel, that's over half of all the cancers you had. As you can see, breast is slightly higher than prostate. New figures show that prostate's actually catching up. And 3rd is lung, and 4th is bowel. So that's cancer incidence. So my next question is, what about cancer mortality? Which cancer causes the most deaths? So out of those 4, which one do you think causes the most deaths? The answer is lung. So if you have a similar bar chart, but have a look what's at the top, by a long, long way, because of course it includes both males and females. Lung cancer is by far the commonest cause of cancer causing death in the country. Next question, sorry. Which cancer is diagnosed the latest? So by that, if you have a look, each cancer generally is put into stages, 1 to 4, depending on the extent of the disease. So when you have a look at the time of diagnosis, which cancer is most likely to be diagnosed at a late stage? Everybody's still going for those prizes and contributing. Thank you. And the answer is pancreas. So I'll try to plot this out in a way that maybe makes sense. So I think this called a scatter graph? I think it is. So on the y-axis, so going upwards, the higher you are, the more common the cancer is. So you can see those big 4, the breast, prostate, lung, colorectal, the 4 common cancers. But on the x-axis, going this way, is the stage when it's diagnosed. So you can see over here that melanomas are not that very common, but generally diagnosed at an early stage. So what is interesting is cancers that are diagnosed at a late stage. If we actually want to make a difference in people's outcomes, we should be able to focus on these. So I've already mentioned lung is pretty high, but there's a little group here, ovarian, gastroesophageal. But by far the latest stage diagnosis is pancreas. And I'm sure that in the audience, people with the same patients with pancreatic cancer, it's such an awful disease, is pancreatic cancer. Similar question, looking at those sort of 4 late stage cancers. Which has got the poorest survival? So there's different ways of designating survival: 1 year, 5 year, 10 years, but I think this one accounts for all of those figures. The answer is pancreas once again. So if you have a look at this is 50 years of cancer advancement. And if you have a look at those top few, the skin and the breast, how much it's improved over the last 50 years. But if you have a look at the purple line, it's pretty flat. And actually, it gives a false representation, because the improvement is almost always due to neuroendocrine cancers, and not the solid tumor cancers. Bill Gates had a neuroendocrine pancreatic cancer and lived for 7 years after his diagnosis. So pancreatic cancer is really the toughest cancer, and it's really difficult to diagnose. 50% die within 3 months and 75% die within a year. And I've tried an impossible task to come up with some sort of top tips and advice for GPs about pancreatic cancer. It is the perfect predator, it's pancreatic cancer, but just a few things to remember. Jaundice isn't important, but generally a late sign. Just don't ignore if somebody walks into you that's coming yellow. They need urgent assessment and urgent scans. Yes, it could be an obstructed gallbladder, but it could become pancreatic cancer. Now, there's something about the pain. We know that the pain is often described as epigastric, borne into the back. But when you have a look back, people often have said it started 6 months ago and then it went away. So a waxing and waning pain is important. And then there's the more subtle signs, particularly this triad of weight loss, steatorrhea, and diabetes. So if somebody's got weight loss, an additional question is, say, do you have oily poo as well? And that will be more of a herald as a GP. And the final thing to remember, although we recommend it to do ultrasound scans, and they'll pick up maybe 80%, but it does often miss a pancreatic mass, and a CT is better. So it depends on where you're working, but ideally either a CT referral or an urgent referral to a pancreatic service. Now, that might not help very much, but I think you've got to remember, even if we diagnose pancreatic cancer late, the earlier we start intervening, the better, because nutritional support makes a big difference to people, and early palliative care can still be helpful. I'm sure, like me, you've seen those awful cases, somebody's been bounced around and been admitted to hospital, and they've never got out of hospital, they've been dead in 10 days. Well, if we can make a difference, perhaps to that last 6 months in life, it is really important in pancreatic cancer. I think the rest of my story will hopefully be a little bit more positive. True story, this one is, as I was preparing this, the theme tune 2 weeks ago came on for Dirty Dancing, and it really made me think about Patrick Swayze, the before and after. And Patrick Swayze sadly died at age 57 of pancreatic cancer. Right, which cancer is the most difficult for GPs to diagnose? By that, I mean, which people, when you look back, have come and seen us a lot and maybe had subtle symptoms that we've not been able to tune into because it's been too hard? And the answer to that one is not pancreas, it's multiple myeloma. Another fantastic piece of work from Cancer Research UK is they did a couple of years ago, it was called the National Cancer Diagnosis Audit. Perhaps people were involved in it. In my practice, we're involved in it. 60 cases, about 10,000 patients, 60 new cancer diagnoses, and we're filled in this sort of questionnaire on each of them. And one of the questions asked is, looking back at this patient that was diagnosed at a certain time, how many months before did they originally come with symptoms, and how many times did they see them? And the average for multiple myeloma was 6 consultations and more than 6 months. And the big problem of multiple myeloma is the non-specific symptoms that people have. I think historically, when I was at medical school, which was many, many times away, they used to call it moans, bones, abdominal groans. But my big tip is just beware that older man with a new onset, unusual back pain, particularly if it's not getting any better, that somebody particularly has never had any back pains before. And I'll come on a little bit about tests later on as we're talking. I hope everybody's still with me. We're up to question number 7. Let's talk a little bit about tumour markers. So which tumour marker is most useful for GPs? So is it a PSA, CA125, a CAA, or P19.9? If you're not sure what they are, I'll try to explain. Well, it's part my view, but it is based on evidence. I'd strongly suggest the best of those is a CA125. But I'll make your life really, really easy as a GP because they're of limited value. And CAA is not specific or sensitive for bowel cancer. It's advanced in most cancers, to be honest. And P19.9 is not actually very good in primary care for diagnosing pancreatic cancer. And so the recommendation for these tumour markers is that they are not recommended. And the path labs don't like us doing it. And the more I speak to consultants, they don't agree with GPs doing it. They are very good and they are used in secondary care, first of all, to decide on treatment, and probably most importantly, to monitor the response to treatments. So they are not a primary care investigation to use anyway. A CA125, however, is a good test. And when to use it? Well, there's something subtle here. Women over 50 with bloating. If that's happening and somebody says they feel bloated, women over 50 certainly do it. And the things not to miss, do not diagnose IBS as new in a woman over 50. And even if you're thinking of diverticulitis, and even if somebody has diverticulitis, it's worth doing a CA125. It's dead easy test. Over 35, as in the result is higher than 35, you do a referral to an ovarian 2-week wait. Now, PSA, we could have a whole lecture, we could have a whole day about PSA. One thing that's very topical at the moment, and I suspect you might be seeing this because I think that, you know, even me in a deprived practice is seeing it. And I think particularly if you're covering sort of other areas in the country or even doing things for private organizations or insurance, we have got and will continue to get more and more men coming saying, I want my PSA testing. And the reason for it and the impetus is behind it is since COVID, we had a dip in 2-week referrals, and almost all tumor types have recovered and more than recovered other than prostate. And it's because the world has changed and those stoical old men are not wanting to trouble doctors. And therefore, there's a real push to find them. I think we're finding the wrong men in this. I very admirably, and I've done some work for Prostate Cancer UK, they're encouraging people to go on this symptom checker. But usually the symptom checker, any man over 50, it says, go and talk about having your PSA testing. So it's a real practical conundrum when we have that. And I've got a little bit of things that you can use here, and the resources available, a fantastic infographic from Cancer Research UK. And what I do with people, I'll text this to them, or I'll show them, particularly before they've come in or whilst they come in. Now, it'll take me a while to talk it through, but I'll try to do it briefly. This split 2 different groups. There were both people without symptoms. So 1,000 men without symptoms didn't have screening, and 1,000 did have screening. So if you have a look at it, without screening, you're going to find 66 cancers. I think that's 66, I'll check my glasses on. 68 cancers. And of which, over time, 7 of them will die. But if you do screening, you will find 20 more cancers. However, the mortality will not be reduced. You will not save any lives. So the conclusion of this, in asymptomatic men, if you check their PSA, it will not save the life. Yes, it may find prostate cancer, but of those 20 men, did they really want to know? Did they want to be impotent or have long-term problems? So I think it's a real difficult dilemma. It's about an informed decision with people. Every man can have the PSA if they want to, but I like people to understand what they're letting themselves in for if that's what they do. So what should you do? Okay, right. Well, first of all, you should certainly check a PSA in these groups, because this is what NICE recommends. Again, I could go on to it, but there's even a dispute about this, but this is the guidance we have at the moment. So if men have got lower urinary tract symptoms, erectile dysfunction and hematuria, we should check the PSA. And there are now standardized reference ranges, which have been the same in all the labs in the hospital at last. And of course, it increases as you go through life. Now, what we don't know about, and there isn't enough research about the higher risk groups, we are aware that Black men and men with a first-degree relative have a 2.5 to 3 times increased risk of prostate cancer. So my view on this is I treat these completely differently, and I tend to not necessarily encourage, but certainly do not dissuade. I tell them this, and most of this group I will do tests on, whereas I tend to find the most of the other asymptomatic men, I'd say over 50% decide not to have the PSA test. And the other thing to remember, depends where you work, but there's a bit of a pragmatic view, which is agreed by GPs like me who do a lot of cancer work and the urologists, that the NICE guidance is flooding the system and we need to prioritize those that are at higher risk. So generally, wherever you work, it'll be over 20 you would refer immediately. If it's slightly elevated, you'll check an MSSU and repeat the PSA in 4 to 6 weeks. And the other thing just to remember, if people have got significant other comorbidities, why bother doing a PSA test? They're not, ultimately, all men that live for long enough are probably going to have prostate cancer when we die. So why over-investigating those that you're not going to make a difference to the life? Okay. I hope everyone's still with me. Question number 8. Negative predictive value of fit. So that is this poo test, poo on a stick that you test. And the question is, what's the likelihood that a patient with a negative test does not have bowel cancer? Is it 990, 99 or 99.9? Those of you used to doing MCQs, as most GPs and doctors are, will have guessed it is 99.9%. Otherwise, I wouldn't put it up there, would I? So fit is definitely flavour of the month at the moment as a cancer test. What it does, if you don't know it detects human blood in the poo, so it's much better than the old FOB. And it's actually better at detecting bowel cancer than the very symptoms and signs that were recommended by NICE. So it's that good. It's almost better than being a doctor. And it's safe. If we don't realise as GPs, actually colonoscopies and CT cholangiograms are dangerous. What is confusing about fit, it's used at 3 different stages in the NHS. Of course, it's used for bowel screening, asymptomatic people every 2 years, 60 to 74, but the level they set is very high. So it's a high threshold of 120, and they're only positive on over 120. We're also recommended to do it for people who are low risk but not no risk, so people who don't meet the NICE guidance for referrals, but we're recommending, so for example, you've got somebody who's over 50 with abdominal pain, you're not going to immediately do a 2-week referral, but a fit is a very good rule out test for bowel cancer. And what's new in the last few months, we're now recommended to do a fit with every single 2-week weight lower GI referral. Now, why is this? You know, earlier when I was talking about prostate 2-week weight referrals, the prostate haven't recovered, but the lower GI have recovered and are now actually 50% higher. So this is graph, you can see the dip was during the first lockdown, but we're now referring something like 15,000 a week of referrals. And basically, it is partly hospitals can't cope, endoscopies under pressure. These are type of political meetings. But more importantly, we've got the wrong people in the wrong queue sometime. And FIT is probably the best cancer test we've ever had. It's a common cancer, and bowel cancer is very difficult to diagnose early. Still 35% of bowel cancers are diagnosed as an emergency in A&E with an obstruction or severe pain. And what we have now, we've got this increasing evidence of value as FIT as a rule-out test. What I'm saying is the negative predictive value is 99.9%. And there's 2 sort of financial, political, I suspect a lot of people in the audience are not like senior partner like me, I'm making sure the money comes in, but whoever you're working for will want to make sure the money's coming in. And the investment and impact fund and the PCN DES, it encourages us now to do more fits, particularly at the time of the 2-week referral. And a little prediction for the future, we're likely to see in the next few months that the national guidance will change, that will say to GPs, unless somebody is at very high risk, for example, abdominal rectal mass, please do a fit before you do a referral. And if the fit is negative and the person has got low risk, you don't need to do a referral. So that's not there yet, but I do predict that that's going to happen quite soon. Question number 9. We'll talk a little bit about platelets. You get the result come back, and so somebody's got a platelet level of 480, and you think, why did I do this test? Or more importantly, why did some other GP do this test and I'm doing a job having to file these results? What on earth does it mean? And I remember somewhere there's something about risk of cancer. What have I had to do practically? So my question is, which cancer is it associated with? And the answer, of course, is if you get E, all of the above, it's going to be all of the above. And they're actually called the Lego C. In fact, Bobby had a good thing. Says, why is it not Lego B if it's bowel? I think the C stands for colorectal. So it's lung, endometrial, gastroesophageal, and the C. I think we use the Lego C so we can remember that. I'll show you the lovely Willie Hamilton. If you ever want to go to a decent cancer talk, go to Willie's talks. He's a fantastic guy. He's a lovely man, and he's an absolute genius. He wrote the NICE guidance and did all the investigations, and he's great company as well. So I think next time, Livi, you'll have to afford Willie rather than me to do this talk. What the reference is there is the biggest ever access resource for GPs from the Royal College. Everybody's looked this up because they think, well, what does it mean? And with his original work, he looked at 40,000 people with raised platelets and tracked them. And he realized that the risk of cancer was pretty high. Now, it was 12% for men in the next year and 6% for women. So if you have a look at that, in adults in our country, If you track them for a year, forget the platelets, 4% of men and 2% of women have got a risk of cancer by the end of the year. So it's just massive business is cancer. But the issue with platelets, it trebled that risk. And it was high, of course, if you were male, it was higher if you were older. It was higher, the higher the platelet counts and the more platelet counts you have. The subsequent work has shown actually a moderate increase in risk in lowish normal, let's say high normal levels, and all men over 60. But what does this mean practically to us as GPs? What should we do about this? Well, here's my practical advice. 90% of raised platelets have nothing at all to do with cancer. They're usually due to an infection, sometimes trauma. So it's often normal and you can just wait and see. And some people have got a chronic raised platelets, so you don't need to panic. But I think there's just something about thinking about those cancers, and you could repeat it. Now, by far the commonest of the LEGO C were bowel and lung. So we've got these tests. We can do a FIT or a chest X-ray. And also, if you talk to patients with raised platelets, what Willie found is those with cancer, 2/3 had symptoms of cancer that you could refer on. Actually, they met the nice criteria. So when you talk to them, they say, yes, I've had some rectal bleeding, or I've been coughing for 4 weeks. So it allows you to do the right test and the 2-week referral. So it's not a simple piece of advice, but I hope that helps give you a little bit more practicalities of what to do. My final question is, what risk of cancer does NICE recommend GPs should act on? Is it 1%, 3%, 5%, or 7%? The analogy I'd give is that, if somebody was to say to you, you've got a chance that your car is going to break down on the way to work, would you take it to a garage or not? And what would you be comfortable with? What level would you be comfortable with? Well, NICE, for some reason, don't ask me why, is chosen a level of 3%. And what I have here is the NICE guidance, because one of the problems is when we're talking about cancer, we could just spend all my slides showing you the NICE guidance. I'm not going to do this. I've been to lots of boring lectures like that, but the link is there. And there's definitely something about just being aware of them. I still have to look them up from time to time, and don't be worried about doing that in front of patients. I certainly am not. So I'm just going to have a little pause there, if that's okay, and I'm going to have Bobby's help and Hemel's help to work out who the winner is of this little quiz. I better just stop sharing now. I don't know how we're going to do this. What I would suggest is, I'm right in suggesting, Bobby, that we don't have any IT to do this.
I haven't kept count, no. So we can go the honesty route and ask in the chat for people to raise their hands if they've got over a certain amount. Neil's happy to hand back over to you for that one.
Okay, so I'm so unused to this type of thing. I only use maybe you can help me while I'm going along. So what I'm suggesting is, okay, as all the participants, there are 10 questions there, and please help me out with this, Bobby. If I want people to put their hands up if they got 6 or more correct out of that, and I'll see the number of attendees. Okay, keep going. Oh, it's going up. I think we've got 129 on the call currently up to. Keep going. Right. So we know that there's 15 people who've got at least 6 correct. So I want you to keep your hand up if you've got 7 correct, but put your hand down if you've got 6 correct. So if you can put your hand down if you're on 6. It's going down. It's going down. It's exciting. Right. So similar thing is, keep your hand up if you've got 8 correct. 8's very, very impressive, actually. My word, that's 8 people. Right. Oh, 7. Okay, so similar thing, keep them going. If you've got 9, keep your hand up. If you've got 8, put your hand down. Oh my word, that's 6 people. Okay, now Hemel, it's not you, is it? This person who's got, no?
It's not me, no.
Okay, so let's see if anybody's got full marks. Anybody got 10 out of 10? So congratulations, everyone. I think everybody's winning. Now, Bobby, depends on 5 people. Do we need a tiebreaker, or are we happy with 5 people?
Tiebreakers are always fun, but I think we can send the goodies to all 5. That's not a problem.
That's okay. So are you all right just to collect people's names? Is
Absolutely,
that okay?
all done.
Thank you very much. Well done, everybody. Thank you very much. I'm very impressed. I think maybe next time you should do my talk rather than me. We just have a little break, Amal. I just thought if people have been going along, if you've got any questions or if there's anything you want to clarify, Amal, or anything you suggest.
Yeah, well, I think a couple of people got some questions which we can use your knowledge on. So first question was in multiple myeloma, and you were talking about back pain. Would you tend to find a new onset back pain to be lower or upper, or does it not matter?
It doesn't really matter because you sometimes get rib pain. So it's anywhere. If you think about it, it's anywhere where there's bone marrow. What I'd be particularly worried about is somebody had back and other pains. I had a patient very recently like this, and I will talk a little bit in the second half about the tests you can do for it to be able to help. And I will talk a little bit about gut feeling as well. So I'll emphasize that a little bit with melanoma. I've deliberately, it's not a common cancer, but I've deliberately included it because of that fact that it is definitely the most difficult for GPs to diagnose.
No, absolutely. I think it is. So another question was actually, which is something that I don't know the answer, and I'd be quite keen to know the answer was. We mentioned that raised platelets can be a warning sign of cancer. It can be indicative of lots of other things. But in terms of repeating the platelets, what time frame would you kind of recommend to give to rule out all the other causes or some of the other causes?
Great question. One of the difficulties here, we don't have an evidence base. So practically, what I would do, I'd just think about that patient. I'd look at the other platelets. I'd probably repeat in about 6 weeks. And my view is, you know, when people say about persistent, they think about all about the guidance is persistent and unexplained. I usually use a term of between about 3 and 6 weeks for persistent. So I think if it's still up in 6 weeks, I'd be more worried, and I'd be more likely to want to review and investigate that patient more.
And I think that kind of follows on to the last question, which is probably very patient specific. So I wouldn't expect you to know the answer, but for people with persistent platelets, and you don't have any kind of identifying symptoms, what kind of tests would you, or investigations would you kind of do to rule out things? And when would you feel comfortable going, I've done as much as I can in terms of cancer?
Oh, it's a great, that's a really good, but that's like the nub of everything here. So what I would do, I'd look at the notes first, and I'd look at other things about that patient. What do you know about that patient? Look at the other blood results. Ideally, I'd probably want to see them and take a history. I'd ask about the Legos-C symptoms and signs of them. The next thing I would do, I'd certainly do a fit and a chest X-ray on that patient. And then, it depends what you've got there from then on, right? So your options are, of course, is, observation, safety netting if you've got these symptoms come back. The other things you could have, sometimes we have access to CT scans. So if you've got access to CT scan, my get out of jail free card is a CT of chest, abdomen and pelvis, which I could possibly do on this patient that I was really worried about. And the other thing we have is the non-specific symptom pathway. Now those are around the country. I'm sure most people have got access to them. So that idea that I've checked this patient over, I'm still worried about them, even the flag has been this raised platelets that I'm not happy with, I think that will be very relevant to refer that patient on that pathway. Basically, the next thing they have is a CT, chest, abdomen and pelvis as their assessment, if you don't have direct access yourself.
Yeah, no, that's really useful. I think sometimes GPs fear doing more tests or kind of get into quagmires, and asking for help is certainly a better pathway. And I know you're going to come on to the gut feeling, but a lot of people do have I'm worried about this patient, but I just don't know what for it.
Yeah, and what we tend to find, cancer pathways are very much silo pathways. They're very, very narrow, and certain things don't fit into it. So the raised platelets, the pancreatic cancers. So some of it is actually just knowing who to ask. And maybe don't quote me on this, I hope there's no managers of the NHS on this. There's GPs, fudge the system. As actually saying, I want this patient sorted out. You've got to be, to some degree, politely assertive, getting things for your patients.
No, absolutely. A few more questions, Neil. So one of the doctors here has asked, would you recommend x-rays in back pain with no injury? I guess specifically talking about the multiple myeloma patients, all of the elderly patients.
Simple answer is no.
That's straight to the point. That's a good one. And weight loss as a sole finding. So I think this happens to me a few times. You see a patient who may be above the age of 50 and they notice to be weight loss, but you don't know what to do next. What's your kind of pathway?
Okay. I might answer that in a little bit more detail. I've got a slide on tests. Basically, I'd use my cancer filter function tests on that patient. Weight loss is a really difficult thing. It is associated with lots of different cancers. Generally, significant weight loss is a sign of cachexia and advanced cancer. So, what are you looking for? Also, we've got no definition as GPs of what weight loss is. So I tend to use either 5% or 5 kilograms as a herald. What it does with me, it just basically gives a flag that fits in with my gut feeling. And what I try to do then is be more assertive with that patient, trying to explore what's going on, exactly the same pathways I've described with the raised platelets. So when you've got those conundrums, ultimately, you go down the same process of reviewing assessment. What we tend to do these days, we tend to work in a situation where we think that everything's got to be done in one consultation. Well, we don't. We can review the patient. We can do things in stages to say, I'm going to examine, I'm going to do some blood tests and not give up on that patient. But it's a difficult thing to find immediately.
No, absolutely. So a couple of questions. This is an interesting one. So there's two parts to this question. So would you recommend using a fit test for younger patients? So I think the question was about, for example, a 25-year-old. And I guess the second part of it, which is very interesting, is if a person has visible blood in the stool, so maybe a hemorrhoid or something, does that affect the fit test result? And what should we do in those situations?
Okay. The bowel cancer conundrum, if particularly when you look at Deborah James and the awareness of it, never too young for bowel cancer. I mean, the statistics are very, very low, but particularly with people with genetic conditions. So you can never say to somebody they don't have bowel cancer, but common things are common. So if somebody has got bowel symptoms, particularly bleeding, and they're 25, they're far more likely to have inflammatory bowel disease. So a better first test is calprotectin. There's a lot of dispute about whether or not you should do both, but generally, interestingly, today I've been doing some guidance for use of FIT and when not to do FIT with a consultant, and we were trying to work out what age, and we came up with a pragmatic view, maybe under 40 do a calprotectin and over 40 not, but there isn't much evidence base behind that. So I think with that patient, you'd be much better considering inflammatory bowel disease. One of the difficulties is we don't have good pathways for inflammatory bowel disease suspects as GPs, and my experience is very poor. Those young patients are often got to be toxic by the time they get seen because we don't have an urgent 2-week pathway for them. So one of the things we do as GPs, perhaps, we're talking maybe 45, we actually do refer them and we bend the rules. I don't, in this audience, I don't dispute that. I often encourage it because if a GP is worried about somebody, that patient, we need to use the NHS systems to get the best for that patient. Second question is really easy to answer. Always do a FIT, even if they've got rectal bleeding. Okay? Doesn't make sense, does it? They've got bleeding. Patients tell you they've got bleeding, but this is the reason. A FIT is not about fresh blood. It's something about sort of broken down blood. And now, if somebody's got rectal bleeding and they've got a FIT that's positive, they are more likely to have a right-sided colonic lesion. Right? So we've referred somebody, rectal bleeding and the FIT's positive, and the people at the hospital know, the lower GI consultant knows about it. What they would do then, they would say, I need to have a look throughout the whole of your colon and do a sigmoidoscopy and make sure that they're looking at the right side. If they've got rectal bleeding and the FIT's negative, they're more likely to think this is a distal lesion. Most tumours are relatively accessible, and they might not do a full colonoscopy. They might just do a full sigmoidoscopy. So that's the reason why it's worth doing it.
Fascinating. A couple of few general questions. I know we spoke a bit about this, but One of the doctors was asking, actually, in a patient with raised platelet counts, would you use any kind of risk scoring tools like a Q cancer risk scoring tool?
But I suggest, Hemel, we move on, because I'll be covering a lot of these points in the second half. Is that okay?
Yeah, absolutely. Let's move on, and then we can keep asking the questions, I guess.
So I love the questions are absolutely brilliant, but I don't want to steal my own thunder, and I'll cover some of these as we're going along, because the questions are incredibly valid. So thanks for all those questions, and I hope we have more time at the end. So also, if there's anything as I'm talking that isn't clarified on questions, please come back to it. Right. So sorry, I'll go back on. So what I've tried to do here, I said that cancer is not binary, so I'll put everything decimal. I've got 10 questions and 10 pieces of practical advice that I've tried to put in themes for you. We mentioned before about, you know, the art of being a GP. Well, the art of being a GP is all in the history. That's how we diagnose most things and how we diagnose cancer. And that's no different wherever you are, whatever type of remote, non-remote, physical work. It's all about listening to people and asking the right questions and being receptive to them. Few tips, know for sure, 4 symptoms. Every patient, every GP should be thinking of cancer: blood, lump, weight loss, and pain. I don't have any magic answers for you, but people, this is what they're worried about if it's unexplained. I don't like using the term red flag in records without defining what it means. I hate it when I've got my trainees that said no red flags. Well, what did that mean? You've got to be specific about what it means. But there are certain symptoms and signs which are really waving a red flag in front of our eyes. So first of all, I mentioned postmenopausal bleeding has got a positive predictive value of cancer as about 15%. If a woman is postmenopausal who comes in with a new breast lump, it probably is cancer, and it's probably nothing else. And also the other thing to remember, which has got a shockingly high positive predictive value, is food getting stuck. If you've got somebody who's maybe over 60, say, when I'm swallowed, food gets stuck here, they probably have cancer. And I'll just give an example, because the question was, should you use Q cancer? Yes, you've got my tip already there. Q cancer is absolutely brilliant. You can do it for individual patients, and you can make it specific. So what you do, you put the age and the postcode of this patient, and I've mapped one out here. All I've said is, you know, this person does smoke, does drink a little bit, and I've put in 2 symptoms: difficulty swallowing and some indigestion. And you can see here this shocking predictive value of cancer of 56% and gastroesophageal of 51%. So you can see how what the importance of that. So that's far higher than the 3% that Nhs recommend. And this person probably does have cancer. Tip number 2. Mentioned a little bit before about gut feeling. This is where the weight loss comes in. This is what actually stimulates the gut feeling. So another great journal, this time in the BMJ, that GPs have accessed quite a lot, is that if you have a look at gut feeling alone, it has got a positive predictive value of 35%. So if you think about rectal bleeding, it's got about 5%, and even coughing up blood's got about 5%. So it's 7 times as good as that, the art of general practice. And it's especially so in older patients and older GPs. It might just be an experience, and it's probably just knowing people, really. And the things when they asked the GPs, well, what actually do you think stimulated your gut feeling? Weight loss, and the fact that they hadn't seen that patient for a long time, that they didn't come very often, particularly men, to be honest. Now, the outcome and the advice was really in 2 extremes. It just recommends for GPs to beware the infrequent attender, because they're more likely to have more advanced cancer and a worse prognosis. But it also says that those people who come a lot, maybe just be a bit safe with them and do some safety netting, which I'll go into in a few minutes. So gut feeling is so important. And that's why I hate it when consultants don't let GPs refer, because I will very much, and what you do is you write on the referral form, and all right, I know they don't meet the criteria, but I've known this man and his family for 30 years, and I'm really worried about him. And you're often right. Next bit of my tips is, wherever you are, examination can be done in some respects, particularly skin things. I can't see why this person needs to be seen face to face. You can look at it, send photographs. I'm not teaching to be medical students, but the ABCD works very, very well. But what we recommended is a scoring system for the 2-week wait, and if they score 3 or above, so look at this one, it's a change in size, shape, colour, diameter is 1.3 centimetres, and the patient comes with itching, and that would score 8, so that's definitely a risk. So you can do skin things. Now, Kemal and I are just going to come to a little bit of a debate on this, and he'll give his view from sort of his Livi experience. I often get asked this: do patients need physical examinations? Consultants want to insist on that, and I always tell them you can't tell GPs what to do because they're autonomous individuals. And really, the answer is it depends on your patient and your situation. So you could say no. Somebody's contacted you, you're doing a remote consultation, it's a 64-year-old who says, I've had abdominal pain for 3 weeks, I've lost some weight, I've had diarrhea for the last month, and yesterday I had some blood in my poo. Well, what are you going to do? You're going to send them in. They need a colonoscopy quickly, don't they, that patient? You could also argue that by trying to streamline them into somewhere else, it's going to delay the diagnosis and slow down the 2-week referral. You may also be planning a test. You may, for example, want to do the CA125, and I'm sure you have criteria of who you should see and who you shouldn't see, and you might have the wrong person in the wrong clinic, and you might say, actually, you need to go down a traditional method. So I think the answer to that is no. However, you could argue yes, particularly for clarifying of diagnosis. I know it might seem obvious, breast lumps, but consultants have shown me referrals for breast lumps that people referred as a 2-week wait with things like lipomas, sebaceous cysts, skin tags, because they've not been examined. The guidance also tells us we should do some examination, for example, a prostate. You could argue gut feeling is better face-to-face. I think a video does work to some degree. And we're also told to refer for unexplained symptoms. So if you've got somebody with rectal bleeding and you examine them, they've got a great big hemorrhoid you can see there, well, it probably is that hemorrhoid. And that might save that person from unwarranted investigations and treatment in hospital that they don't need. I'm just going to have a little pause, and Hemel's going to come in with his view, which is a lot more experiential than me about working virtually.
Yeah, no. So I guess, within Livi, we do digital consultation, so we probably have a bias in terms of the benefits of it. But there are lots of things that we have learned that is different to kind of normal general primary care. And one of the things that I think is the most important thing is gathering information prior to the patient actually in front of you. And at Livi, you can get a lot more information from using symptom forms. What it really does is, yes, the information could be vague, but it gives you an idea of what you're looking for. And, Neil, you mentioned a lot about looking through the notes and things, but if someone mentions something abdominal pain, it really should click in your head going, well, actually, is there something else that has happened in the past? What is going on? And it allows you that time to focus really on the history with that patient. Primary care has changed a lot, and I think in the last couple of years it's desperately changed from because of COVID. So we're doing lots more telephone consultations than we ever did before, and we're trying to move in normal practice to more face-to-face. But the reality is that more and more patients prefer things remotely. And one of the things that I am very strongly for is video consultations. You really do get a better rapport with a patient, and getting a better rapport with a patient just gives you that time to take the history. And you're much more attuned to someone listening to you, and you can see kind of more facial expressions and really get an understanding of your questions rather than going, have you got a cough, yes or no? People will tell you a lot more information. And I think videos do get you comfortable. Like I've only met Neil over video, but I feel like we've had a much better rapport over a video. But if we did it on the telephone, we really wouldn't know each other. And the gut feeling part of it, it's never going to be as good as face-to-face, but I think people tend to see there's something wrong with that patient. I'm just looking at their face, they look thinner, they look a bit more frail, they just don't look like what I would expect them to. And especially if you've known the patient previously, just switch to a video. You will see so much more information about it. I think in personal circumstances and patients I've known, if instead of having a chat to them on a telephone, if you saw them on a video, some real alarm bells would be ringing, especially when you don't see people face to face as much as possible. And I think one of the things that we really try and focus on in Livi is giving lots of people training, experience, confidence in video consultations, spending time to open people's minds about what you can do online, what you can't do, which is probably equally more important, and thinking a bit more outside the box whenever we're doing things for it, and then using the technology. So we mentioned the skin conditions, and getting good quality photos will allow you to zoom into them. If you get real high resolution photos, which most smartphones have, you can get a lot of information from it by zooming into it. And asking people, like, I think the world has changed a lot. People are recording a lot of things with them, so that people do record their weights on the phone. And if you as a doctor was shared that information prior to seeing them, then lots of red flags will come up to you, or lots of kind of information will come up to you and go, actually, I do need to worry about that. And when people, encouraging your patients to do that and just recording your phone is so much easier than doing it when they turn up in the clinic. And things like diaries and other things, we really do need to start using technology. And that's what we're trying to do in Livi, to substitute face-to-face partly, but substitute actually going that general practice is changing. There's no longer as many people who are in one practice like Neil is for many years, who know patients, and how do we change with that? So, what sort of technologies can we use to get people the information that to the doctor that they're seeing at that time is my thing. So I do generally think video in particular makes a difference to telephone, and it's not a substitute for face-to-face, but I do think we need to use the video element as much as possible when we're doing things remotely.
Thanks, Hemel, for your wisdom. That's really important. I think that's very relevant to the audience. And I must admit, thanks for you coming in. I'm a bit of a dinosaur in the way that I work, and I want to embrace the way that you're working. Right. This is a busy slide, but I was asked at the intermission, what tests would you do? So these are my top 10 cancer hunters. I have a look at them. There's nothing unusual there, is there? The first 9 are my routine, and the 10th are backup. Okay, I've mentioned the first 3 already. So I'll give you a few top tips. Iron deficiency anemia is a herald for cancer, particularly if it's unexplained. What do we mean by iron deficiency anemia? A hemoglobin in a man less than 130, in a woman less than 120. A low MCV, so that might be 78 depending on your lab, and a low ferritin, and my lab's reference range is 10, is the lower limit to normal. And if somebody's got that and they're over 60, they need referral. And you'll have 2 different options. You might have an iron deficiency anemia pathway, and that's great. But if you don't, they need both upper and lower GI investigations, because if you only do one, you might miss the other. Next thing about leukemias, people are worried about leukemias, but actually from a GP, so it sounds a bit crass as this, but leukemia is probably the easiest thing to diagnose. The conversion rate for hematology, actually, of referrals we do, of 100 referrals, how many have cancer? For bowel cancer, is about 5%. For hematology, it's about 50%, because what usually happens in leukemia is whoever looks at it in the lab has said, I think this is leukemia, we're going to do a blood film, please can you refer? Now, the subtle signs of leukemia in a full blood count are either a pancytopenia, when everything is low, or a low hemoglobin, low platelets, and a very high white cell count, which will probably indicate what sort of tumour type it is. So I wouldn't be too worried, because it usually tells you on the report about leukemia. Sodiums, I hate low sodiums. I suppose every GP does. What happens? You got a sodium of 127, and it's in your inbox, and you think, well, who's done that? Why have they done it? Just by experience as a GP, the majority are due to diuretics. So you just stop the furosemide, benfluoreside, and it gets better. You have a good proportion that is just diet. Older, often ladies on the tea and toast diet that need a bit more salt. But there is a very small but important percentage that a persistent low sodium is a sign of a syndrome of inappropriate ADH, which is caused by lung cancer. So it's just something to think about. So if you're getting a persistently low sodium, I'd suggest doing a chest X-ray. Of course, liver function tests are going to be deranged in any HPV cancer, so that advanced pancreatic cancer or liver secondary. So you need to do scans for those things. Calcium is going to be elevated if you've got metastases. Now, which cancers metastasize to the bone? Well, quite a few, but the way I remember it is they generally the hormonally sort of influence cancers. So commonest will be prostate, then breast and thyroid, and adrenal as well is the other one. And I'll mention multiple myeloma in a second to finish off, because again, I think we need to focus on that. Next question, GPs often ask me, which is the best inflammatory marker? Well, if you could only afford one, I'd do a CRP, because it's an acute phase reactant and it's generally a sign of anything. But if you don't do an ASR, you might miss a multiple myeloma. So let's just focus on multiple myeloma. Somebody with back pain that you're worried about, I wouldn't, unless I was thinking about a wedge compression fractures of the cause, I would not do a back X-ray. I would do an ASR. So that man, if his ASR comes back at 75, I am worried about him. The other thing that would be a herald of a multiple myeloma would be a raised calcium, and in advanced disease, renal impairment. 40% of multiple myelomas present with acute renal failure. So you're going to get a raised creatinine and urea in that patient. So number 10 is my second line for feelings of multiple myeloma. So I'll do the first 9 first. And then if I was worried about a multiple myeloma, I would do both a plasma electrophoresis and the Bence-Jones urine. The reason for doing the urine is 1/3 of multiple myelomas produce small proteins which sneak out in the urine and you don't see them in the blood. So if you don't do the urine test, you'll have a normal electrophoresis and think that they don't have multiple myeloma. So that's why you've got to do both. Okay, so we're nearly finished. Last 5 tips. Are tests any good? Well, the commonest things we can use is chest X-ray and ultrasound scans. Not all of us have got access to CT. I'm very lucky that I do have. Now, chest X-ray gets a bad press, but actually, if you have a look at the negative predictive value, the fact that if it's negative, you can reassure people, it's pretty high. But the thing to remember is 14% of lung cancers are in non-smokers. The list I showed you before of common cancers, if you had a separate list for lung cancer non-smoker, it would be the 7th cancer in incidence and higher than the 7th in cause of mortality. So don't just do chest X-rays in smokers. Now, people often ask, chest X-ray is negative, I'm still concerned. Well, you've got 2 options. You can either do a CT if you want to, or you still do a 2-week wait referral. NICE guidance is very clear on that for lung cancer. You can refer if you're worried about anybody, even with the normal chest X-ray. Lumps, if you got access to scans, the scanners, the radiologists tell me that most GPs, when they're worried about cancer, it turns out to be a lipoma or sebaceous cyst, which is good news. But the thing we're looking for is sarcomas and soft tissue sarcomas. How you diagnose is with an ultrasound scan. And we should refer immediately if it's a more than 5 centimetre lump, even if you think it's a lipoma, that warrants a 2-week referral. And of course, scans are very good for gynae, probably even better than CTs if you do both the transvaginal and an abdominal ultrasound scan for endometrial and ovarian tumours. Next tip. We've talked a lot about the statistics of negative predictive value, but if you turn it the other way around about sensitivity. So one way of looking at it is what of cancers, if you just relied on what test, what percentage of cancers would they miss? So you can see all these tests are not perfect. Although FIT is a fantastic rule-out test, you can't rely on it on its own. So just have that air of suspicion. One of the questions earlier on is, well, when would you repeat the platelet level? People often ask me, when would you repeat the chest X-ray? And I'd say if somebody had new symptoms, and if they kept coming back with the same thing, I'd repeat the chest X-ray. PSA is not a very good test, to be honest. But it's all we're going to get. Come back to Hemel. Do you want to just think about, would you just help us out from your perspective?
Yeah, so I guess this is just kind of talking about what we do at Livi and what we can replicate everywhere else, really. So one of the things that we, Neil's talked a lot about tests and how to recognize cancers, and I guess the other part of the parcel is the patient itself. And what the aim that we want to do is improve the patient journey as much as possible. So there will always be services like Livi who will take some pressure off in the system, and there will always be remote kind of services. And what I think everyone should try and recognize is every time a patient is asked to come into a surgery, it is a big deal for them. It takes a lot of time in, so trying to reduce the touch points as much as possible. So whenever we're doing tests and needing physical examination, is to kind of think about the journey the patient's going. Can you do the test first? Do you need to do the physical examination first? Is it better trying to minimize the number of doctor contacts and try and make it as streamlined as possible? If you go to the next slide.
Thank you.
And then sorry, again, next slide, Neil, sorry. Yeah, and so the communication with patients. So I think a lot of the times medics and myself particularly focus on symptoms, focus on like what we need to know and the knowledge of it, but actually most of the times the patient tells you everything if you ask the right questions, if you ask them in the right manner. And the longer I've been a GP, and I haven't been a GP that long, but I think when you first started and you used to hear about ICE and you used to think, oh God, this is just something I need to do for CSA practice. And the more experience you get and asking people about their concerns and what they're going on, it seems to be more and more valuable. And really listening to your patients is a major thing. And I think that's one of the things that I personally have learned from. The other thing is that you can try and, whenever we're doing things and we're working remotely and you don't have that relationship with a patient, is to really spend time on that history, but also spend time on the understanding from the patient side of things. So summarizing and checking with the patient, sharing all the uncertainty that we have, because we don't know whether something is cancer or isn't cancer, and making sure that the patient really does understand what your plan is probably the most important thing for it. And it is, we feel like you should do this in video, and people do in video a lot. So just wanted to kind of get that communication with patient, which is massive in my view.
Yeah, I would agree, and I do think that's harder remotely. I mean, I have in a way a very hard life, but such an easy life. If patients get to see me face to face, they think they won the lottery. And not that I'm particularly good. It's just I've been there a long time, and there's a massive demand on it, and they'll forgive me things. They'll forgive me for making a mistake, probably because I try to communicate them. But I just think there is something about the word cancer and actually externalize it quite early on. What is it you're actually worried about? Yeah, and actually sharing that and actually say, well, let's see where you're coming from, and I'll try and make sure. We can never be certain about these things, but I'll go as far as I can to try to help you to either exclude that or diagnose it if that's the case.
Yeah, no, absolutely.
And the other thing, just if things are going to go wrong, with GP, it's two issues that patients don't like. It's when they feel they've not been communicated with or not being listened to, and then ultimately, if you haven't written it down, it's not there, is it? Now, I'm not by any means. This is where I'm going to go wrong sometime, because my note keeping is terrible. I'm sure yours is much better than us. So I sort of just rely on knowing people all the time, and I'm trying to get better at this. But efficient note keeping, it is all in the history, code things. Now, the other little tip, I'd suggest you use in negative findings, and a simple way of doing so is sort of, if you think about a systems review. So somebody's coming with abdominal pain, and I would write down no weight loss, no change in bowel habit, no rectal bleeding. I'd actually define those in my records to show that I was thinking about bowel cancer. Abbreviations again. We could talk a little bit about quick codes and text. I know that there's stuff on EMIS and other things you can begin to use that can use repeatedly. But the other thing that's really important is just a little bit of something, rather than just all about the history and examination. Include something about your management plans and your thought processes and what you're thinking about with the people. And I've mentioned this before about safety netting and red flags. I think with safety netting, it's about being specific. So your CA125 is normal, but if your bloating persists for another 6 weeks, I want you to contact me back, and I'm going to look into it in more detail and actually to document that. And I find people are really confident with that and very rarely trouble me again. And I feel confident I've done the right thing. Mention a little bit about safety netting, some tips here. Again, a fantastic resource from SARE UK about safety netting. But really, in the context of this, we've talked a lot about the history taking examination. I think there's something about the next steps in things. Again, if things go wrong with cancer, one of the commonest reasons that GPs get in trouble with litigation is not acting on the results. And one of the challenges are, wherever you're working, there's a mixture between a personal responsibility and a system responsibility. And how do you address that? But I think we have to consider care longitudinally, and that's what I love about Livi. They do that, whereas other organisations often don't, and just want to step in and step out without considering what the next step is.
Yeah, and I think this brings us on to a lot of what you said is in this slide. I think the most The biggest change that we have is, whilst we're working with Livi, what we've noticed is that we work with multiple partners, and your consultation notes are not just a record of the interaction that you have with the patient, but it's also a way of communicating with any following caregiver. And that's why I think I 100% agree with you. It is so important to write exactly what you were thinking and the good management plan, so that someone who follows up with it understands completely what's going on. And so things don't get missed. And so gone are the days of abbreviations, because it probably won't be, it may not be you who sees this patient again. It could be anyone else. And it helps your colleagues to understand what exactly it is that was worrying you, and so that they can pick up on it, which is probably the most important thing that we've learned from it. And if you go on to the next slide, we tend to have, you know, we've thought long and hard about how can we make the service the best that it possibly can be, and how can we ensure that all the doctors who work for us are given all the support and tools enabled to work in this new way of working. So we have spent lots of time setting up systems so that every one of our clinicians is empowered really to raise any incidents or request any follow-ups from the admin team, but also raise anything that they go, do you know what, I just need someone who is there every day to follow this patient up for me, or do this because I'm concerned about something. We additionally then, with everyone who works for us, we do look at their notes to give them any kind of tips and tricks, and go, and you know, this is areas of improvements, or this is what you've done brilliantly well, so that it makes our service work better with our partners, and it makes all of our clinicians understand where they can improve and where they're doing brilliantly against it. So we do spend a lot of time looking at individual clinicians and giving them training and development needs, and I think we've had positive feedback and positive outcomes from that. And as a system, or as a service, I guess, we are spending a lot of time doing cancer audits or other types of audits to try and get any learnings from there. And then, you know, I don't want to bang on about Livi, but one of the things that we are very proud of is trying to do lots more training and education things. So getting Neil to give kind of give talks and improving everyone's training and education is a passion of ours, and we hope to do lots more of these things, really. I guess this is your final slide, Neil.
It is. So thank you. That's a great way to round it up, really, just in concordance with, you know, if you're going to make a difference with cancer, and this is what I'm passionate about, and thank you for everybody for tuning in, there's just something here about understanding it and then picking those things up earlier. So just really some take-home messages that what you can do as a next stage, you know, something about reflecting on the learning that, you know, for your appraisal, maybe 3 take-home messages: use FIT, consider multiple myeloma, something like that. And actually what actually shows the impact if you apply it to patient care. So if in the next few months you say, actually I've done this differently as a result of that, I think that gives you extra bonus to you. Most of us are problem solvers as GPs, and so we tend to work on puns and dens, as in the patient unmet needs, doctor's educational needs. Somebody comes in, you know, give an example. Somebody comes in and says, oh, my mum and my auntie have got breast cancer. What's my risk? What should I do? I don't know if I'd have a straight answer to that, but I know where I could find it. And the 2 best resources are there, which have got fantastic GP resources, both on Cancer Research UK and Macmillan. Macmillan have got a whole page on that, or a whole few pages on that, to be able to answer that question of how you assess people and do a risk assessment of familial risk. And things you can do, I know it might be harder working remotely, particularly the middle bit regarding audits, but you can do, I'll call them learning event analysis. We should only call them significant event if something's significantly gone wrong. So something about a cancer case, just really any cancer case, any new diagnosis of cancer is a learning event, so you can do something about that. If you want to do something more detail, you could have a look, you know, if you are part of a group of something, you could do an audit, maybe look, for example, if you wanted to shorten the numbers, maybe just look at men over the age of 65 with a raised platelets. And the other thing that some people manage to do, no matter where they work, is maybe to keep a track of the 2-week wait referrals and what happened to them at the end, almost like a rounding thing that, you know, in the last month I've done 4 2-week wait referrals, and this is what happened to them. 3 turned out to not have cancer, but 1 was a lung cancer, and that patient's doing well. So I think just to say thank you, and to particularly Harriet, Bobby, and Hemel for orchestrating this. My message is, I'm just hoping, as I said at the beginning, that tomorrow, if you see some patients and you're thinking about cancer, you can do so, feel a little bit more confident and competent to do so. And that sort of words that you associate with cancer, some of the fear and some of the death, some of the litigation is lifted, and you see it more positively. Going back to my story about the triathlon, I think in cancer, you've got to take any win, any way that you can get it, and you've got to celebrate it as much as possible. And an early diagnosis of cancer for GP is a big celebration. So thank you very much.